start? Yeah. So hello and very happy Monday to everyone. On a Monday morning to have 16 people join the Fresh webinar series is great. My name is Mohini Venkatesh and welcome to the monthly Fresh webinar series. Today, this month, we're commemorating World Health Day, which was on the 7th of April. And to celebrate this very special day, we have a very special guest speaker, Professor Don Bundy, Professor of Epidemiology and Development at the London School of Hygiene and Tropical Medicine. Many of you on the call are familiar with Don and his work over several decades, at least 30, to my knowledge. He's a senior advisor to the Children's Investment Fund, CIF, and in his previous roles has been with the Bill and Melinda Gates Foundation. He was a lead specialist for health and nutrition at the World Bank for close to 15 years and professor of epidemiology at Oxford University. And today, Don is with us to share Volume 8 of the Disease Control Priorities 3 called Child and Adolescent Health and Development. Don is the lead editor of Volume 8 of DCP 3, as it's called. And I hand it over to Don. Don, welcome to the Fresh webinar. Just before that, Song.
Hi, this is Sung. Sung Wei, School Health and Nutrition Senior Director of Save the Children. I actually wanted to take a couple words to also introduce Don. But before I do that, could all the people who are online and not speaking, can you mute yourself? There's a lot of background noise. So thank you for muting yourself. So get rid of the background noise. That would be useful. I actually wanted to introduce Don because I feel like my career with School Health and Nutrition really began when I started to work with Don almost 2 decades ago at the World Bank. And I know that Save the Children's work also began with the input of Don. So everything we do on School Health and Nutrition, I say everything I learned from Don, everything I know about School Health, I learned from Don, but I guess I've learned since then, but I do want to just say there's quite a lot of people in the School Health and Nutrition field that have learned very much from Don, and I do think Don has set the stage and direction of a lot of the research and implementation around the world around School Health and Nutrition, so it's really exciting to have him speak today. Thanks. Now to you, Don.
Okay, well, hello everyone. Good morning, good afternoon, good evening. I thank you very much, Sung and Mohini, for those kind words. I much appreciate them, and I like the opportunity you're giving me here to talk about the latest place we've got to in the school health area. And I think in this discussion, since we're all part of the Fresh partnership, I think the aim, I will try and focus this really more on the school health part of the discussion rather than the other areas that are covered. I can hear some people having a conversation on the line, so I'm hoping some people will mute their microphones. So what I wanted to talk about today was a book, an analysis called Disease Control Priorities, and I thought I needed to really start this with a quick word about the what the book is. So if you don't know what Disease Control Priorities is, you may well want to look into it a bit more, because it's actually really useful. This started in 1993 when the World Bank wrote its annual World Development Report, and for the first time focused on health. This was actually when when Larry Summers was the chief economist at the World Bank, and he asked Dean Jameson, also a famous economist, to take the lead. You'll all perhaps have heard of Larry Summers, who became the Secretary of the Treasury and became president of Harvard University. So these guys decided it'd be a good idea to really focus on the economics of health. And the World Development Report of 1993 was enormously influential because it was one of the first really sort of official documents that said investing in some things gave you a better return than investing in others when we talk about health. And let me give you an example of its influence. So Bill Gates says that he focused the Gates Foundation on health rather than some other development area because of reading about that, and because of reading about, for example, how remarkably cost effective the vaccinations could be. Hopefully he also read about how remarkably cost-effective deworming could be, because that was also a topic back then in the 1993 World Development Report, and indeed was one of the launch pads for thinking about fresh school-based deworming. At the same time as that report was produced, which was a World Bank report, all of the background documents that led to the report were written up in a book published by the World Bank with Oxford University Publishing House, called Disease Control Priorities. So that's where the name comes from. So all the analytical work that was used for the World Development Report was published as a standalone volume. And that's the one that probably people on this call would find most useful, because it's got the detail that we need. And it was widely distributed and went out to ministers of health and ministers of finance, and became a standard book that ministers of health would use before they spoke to the Minister of Finance, and the Minister of Finance would read before speaking to the Minister of Health. Indeed, Director General of WHO, Tedros, when we launched the book this year, the version of the book this year, he said that he would be using it in exactly that way, that the disease control priorities books were the standard resource for looking at the economic effectiveness of different health interventions. So 1993, the first one was produced, was immediately influential, including to the Gates Foundation. Indeed, Gates Foundation subsequently supported a second edition, which came out in 2006. So again, led by the World Bank, published by the World Bank, but in this occasion also supported by the Gates Foundation, which led to the third edition, which is the one we're now talking about, which is why we call it Disease Control Priorities, DCP, DCP3, DCP third edition, which has just recently been published at the end of last year. So if I can have a look at the next slide, please. This is the overarching purpose of the disease control priority series. As I say, these are to help set the economic priorities in health for, and this is particular emphasis for low and lower middle income countries. Those are the particular area of focus. And all of the editions up till now have been huge books that you couldn't easily read in bed. And this time round, we've got a change. So if I have the next slide, this lists the 9 volumes that go into the third edition of Disease Control Priorities. And you can see they range from essential surgery which is volume 1, through early child health, so reproductive, maternal, newborn, cancer, mental health, cardiovascular health, HIV, STIs, tuberculosis, malaria, and neglected tropical diseases. So volume 6 is actually now called Major Infectious Diseases, injury, and then child and adolescent health and development, which is the one we want to talk about. The 9th volume is a roll-up of all of the previous 8 volumes, so it's a sort of major conclusion. And these volumes now are all available. If I could have the next slide, please, just to give you a sense of the task. So 9 volumes, took 7 years to put them all together, 33 editors involved with what I should tell you is that there are, as I say, 9 volumes, so 9 lead editors and 33 editors, 170 chapters, more than 500 authors. So it's a major task, and it's only now being completed as a task. But of course, the real work now begins in getting those messages out. Now, the next volume, please. The sense of the volumes, they all cover these sorts of topics. So we've got them all listed here. That the burden of disease, the essential packages, and what that means is very specifically trying to come up with a package that describes what are the key areas of intervention, the most, as it were, the most cost-effective, most high value for money areas of intervention, and then looking at issues like effectiveness and so forth. This time, as well as the packages, we've also focused on platforms, and of course the schools come out as an example of the kind of platforms that we would be interested in, but other platforms include hospitals, campaigns, and so forth. So all of the 9 volumes try and cover all of those topics. And the next slide, please. So you'll have got the message. DCP3 is largely for policymakers, but obviously has all kinds of implications for the rest of us also working in that area. Oh, so let me come now to the issue of the volume we're going to talk about today. So if I could have the next slide, please. This is volume 8, Child and Adolescent Health and Development. There were 5 editors involved in this. So Nananthi De Silva from Sri Lanka, who many of you may know, Susan Horton on nutrition from Canada, Dean Jameson, the lead economist on this, who is also the lead editor for the series, and George Patton, who was and indeed who is the lead on the Lancet Commission on Adolescent Health and Well-being. We're the editors. Everything that was written we have read. Everything that is written has also been peer-reviewed by the Institute of Medicine in the US, because that's one of the special things about the disease control priorities, is that all of the text and all of the published work has gone through a peer review process. All of the chapters are multiple author, with the intention that makes sure that they express a variety of, they cover a consensus view in the way in which they express. I should say that this is not a medical textbook. So what you find here is a very specific focus around economics and health, and where an area we were unable to find sufficient detail in, then that doesn't appear in the text. So what we can say is that now for the first time we have a real focus on child and adolescent health and development, which we hadn't done in the previous editions. But at the same time, what we don't have is a focus on everything. So I apologize if any of your favorite areas don't get covered. So going to the next slide, just to remind you that there are 9 volumes, that this is that the 9 volumes show you, you can put these 9 volumes up on your bookshelf, and this is what they look like, and that you can get all of these for free from DCP-3. That's the website, www.dcp-3. You can either download them as electronic versions, or you can request printed versions. Those are the that's what it looks like. So now, what has it actually got to say for itself? So if I could have the next slide, please. So what this one focuses on is focusing on the issue of human capital. We published the volume, and alongside it, we also published a summary in Lancet, which provides a more digestible overview of what are the conclusions. And the main conclusions are around the fact that developing a human being is a 2-decade exercise. It's common sense for anyone who's got children, or indeed anyone who looks back on their own life, that development is not about the first 1,000 days only, but about the whole 8,000 days that it takes for a human to develop. And in that period, there are particular phases which are particularly sensitive. And that's really one of the main messages that I'll come back to on this. So if I go to the next slide, please. I also want to just briefly mention some of the process of production, just to say that there's a great deal of discussion and consensus in building towards that. So got some slides here showing meetings in China, in Addis Ababa, and with WHO in the Middle East region. The next slide, please. But let's now come to the main conclusion areas. So this is a slide which many of you will be very familiar with. It's by Professor Heckman, the Nobel laureate, and this has been shown over several years now. People have looked at this as part of the understanding of why the early parts of development are so important. So this shows development from birth through to beyond school, and it looks at the return to investments in human capital at different points along there. Now, this curve is a theoretical curve. This isn't a set of data, and it was produced to try and illustrate the fact that if early development was crucial to everything else, then clearly early development would be the most important time to invest. And this is really what gave rise to the focus on the 1,000 days, the first 1,000 days. But of course, if you look at this graph, and if you actually now started to plot returns to investment at later ages, you'd find that the curve is not that shape, and that there are periods during preschool, during school age, and into adolescence when the returns to investments are also extremely high. So the argument here is that this curve has certainly been very influential and important in helping us recognize the need for investment in development. But what we now need to do is to think about that line as being a much flatter line, and that we need to invest in development at several points in the life cycle and not only at the beginning. So what do we mean by that? The next slide. And the next one, please. So this is a slide where we've tried to illustrate in a simple form some of the data that we're trying to get at. So if we look at this, moving left to right on the slide, what we're seeing is age. So it's going from around 0 to around 20. If we look at the top third, we could see that there is some that's looking just simply at height, growth. We all know that the greatest growth in children is at very young age, as babies. Then there's a kind of period of relatively slower growth, and then 2 pubescent growth spurts for females and males at different age points. Growth spurts during which children start to grow again at the same rate they last grew when they were 2 years of age. But of course, they're now much bigger. They're much bigger individuals, and in terms of biomass increase, we're seeing a dramatic change upwards in biomass. And I always find this one of the more convincing pieces of data, showing that there are key places in the development of a human being where we see a need for investment. In this case, we're seeing major needs for investment in nutrition. That's what we're illustrating here. But we all know, of course, that during these pubertal changes, much else changes in terms of the psychology and the behavior of the growing human at the same time, and that there are all sorts of other investments that need to happen then in order to ensure a safe passage through development. If we take the next phase down, this is looking at changes in brain development, and again we can see that brain development happens at different phases as you move forward. It's controlled in different ways. Below that is actually a figure looking at the volume, the size of different parts of the brain during changes, during age changes, and you can see that some parts of the brain actually increase in size, and some parts of the brain actually decrease in size as you age, as a young person ages. And if we think about those issues, what the evidence shows is that there's a whole process going on here. So certainly when I was first taught about development, we talked about how children, babies were born when they've got big heads because the brain is pretty well fully developed when they're born. And indeed, in terms of mass, that's more or less true. There's a whole chunk of brain that's there already, and that brain is very much determined by what goes on in utero and indeed during early life. But what we know now from the last 15 years of brain development research is that there are massive changes that go on in the brain at different phases in life. And the one that I think is always so striking is the change in relatively late adolescent, this process called synaptic pruning, which means that the synapses that haven't been used are taken out of action. They're pruned, they're taken out, and the synapses that are most used continue in action. And those are, in fact, also subject to myelination, which is the other piece that happens. So myelination around that time increases the rate of carriage of neural messages at the same time as all the side branches are being cut short. So that what we're seeing going on at that point is that the whole brain architecture, so not the size of the brain, not necessarily the shape of the brain, although there are shape changes because of some parts getting bigger and some parts getting smaller, but the functionality of the brain is dramatically changing around that time. And this is the time also that people throw their hands up in horror and talk about adolescence. And this is the time when some of us were recognizably badly behaved. That's a period of major behavior change. It's also a period that sets mental health issues in motion. So that's when mental health problems tend to most commonly emerge. It's also a time when behaviors, often lifelong behaviors, are set in place. So what I'm trying to say here is there's a lot going on, there's a lot of change going on, and we have to make sure from a health point of view, from a nutrition point of view, that the young person is well equipped to deal with all of those changes. And those changes aren't just at the beginning, those changes are happening right the way through those 20 years. In fact, and if I could have the next slide, please, one of the things that came out when we were looking at this was that we don't even have a very good language for talking about these issues. So here's looking at childhood. So here's a graph, a little complicated, but it's age again along the x-axis. Childhood, adolescence, youth, trying to get a sense of how development happens at different phases. And in fact, we discovered that the terms dealing with school age were very flexible, and that people had no really standardized terms for what school age really meant. So I think we ended up with 5 to 14 as a standard there. But the concept of middle childhood, which is a term that's widely used in psychology, we also brought that into play here as a way of talking about 5 to 9-year-olds. Adolescence then covers the sort of 10 to 20-year-old, but then there's early adolescence and late adolescence, and adolescence overlaps with youth. So we ended up in saying that there really seemed to be 4 phases that we saw as really particularly important. The first 1,000 days, the middle childhood growth and consolidation, the adolescent growth spurt, and then the period of adolescent growth and consolidation that happens approximately between 15 and 19. And so trying now then to think about all of these as important phases in the development of a human being. If I could have the next slide, please. So that's just again just summarizing those points, and perhaps it's worth saying that in terms of the book, in terms of the volume was focusing really on children over 5, because volume 2 focuses on children under 5. So most of what I'm going to say is going to be more around the over 5 area. So what we produced from this were 2 packages. If I have the next slide, please. We produced 2 what we called essential packages. That's the language that's used in DCP3. One was a school age package for 5 to 14-year-olds, and then an adolescent package going from sort of 15 to 19 years. The school age package includes both children in middle childhood, the 5 to 19-year-olds, and early adolescence. So it's both of those. And what the school age package is defined by is really by school-based delivery largely, whereas the adolescent package for the older adolescents requires a much more mixed approach, especially in low and middle income countries, because very many fewer children, especially fewer girls, are actually going to school at those ages. So media and accessible health systems become important in that age range. So if I could have the next slide, please. I wanted to show you this one, which is this is actually taken from the World Bank, and it's an attempt to look at access between schools and these interventions that we're talking about. So here again on the x-axis we've got age from 0 to 20, and what we're looking at on the y-axis is the school enrollment percentage, just an average, a sort of illustrative profile of primary and secondary education. And then those lines at the top are just to give an idea that there are different things that you need to do at different points in the development process. And what's important to note here is that the school is actually remarkably good at addressing a very large part of this population, but that it tails off both in the early part. We can see that preschool enrollment is actually a fairly small fragment of this, obviously needs to increase, and also in the higher part, so that once you're talking about secondary education or tertiary education, again, a serious drop off in low and lower middle income countries, especially of course with girls. That's a picture, as it were, an illustrative picture from the World Bank. So I wanted to show next a picture, a real one. Next slide. This is from China, showing a reaction to that. And we've been working with China during the development of this this volume, and indeed from an earlier period too, just to show the way in which China has reacted to this idea that there are different phases which require different sorts of development, different sorts of investments to coincide with human development. That different phases, different programs are required at different stages in life. And I just find this quite a compelling slide, because it shows how across the 8,000 days, including, of course, the first 1,000 days, there are clear investments both in education and in health that can help children to develop. Probably worth saying that this program for China was very specifically targeted at the so-called left behind children. So these are the children, particularly in the western part of China, whose parents had gone to the east to earn money there. So these are disadvantaged children, and this is a way of looking after disadvantaged children, essentially from birth, indeed a little before birth, through to to the first time they get a job. And what we don't show here, we show the vocational training, we don't show that they actually also had job finding efforts at the end of it. So this is a sense of how you can really look after the development of children over the 8,000-day period. Okay, let's go back to thinking about the packages. If I go to the next slide, please. This is looking at the packages in two ways. First, on the left, we have a cost-benefit slide showing costs rising on the x-axis and benefits rising on the y-axis. So we can see there are some interventions which provide real benefits at relatively low cost, and some have higher costs. If we go over to the set on the right, the two pie graphs, one is for low income countries, one is for lower middle income countries, and they show the relative costs of different sorts of interventions. And you can see there's a cluster of interventions which are at very low cost as individual interventions, and that then the school feeding, which is the majority of the space in both of these pie charts, is the largest cost, which isn't unsurprising to any of you, of course, because school feeding is something you do daily, and it involves the cost of food and all the rest of it. And we're here comparing it with things such as vision screening and deworming, which are relatively infrequent interventions at relatively low cost. But that doesn't make school feeding a bad buy. I want to illustrate another point at the next slide, please. The next slide. I just want to emphasize that with DCP3 we really focused on the health and nutrition returns to an investment. If we take school feeding as an example, actually the greater benefits, the greater returns on school feeding are to education, which is impacting on enrollment, learning, and especially girls' education, on social protection. In fact, that's the main reason most economies provide school feeding, so it's a way of supporting the very poor. And also rural economies, that if you buy the food for the children in the same area that the school, where the school is, then it's actually a straightforward investment in smallholder agriculture. So DCP3 doesn't go into this in sufficient detail, I think, at this point, but I just wanted to make that the fact that something's high cost doesn't mean that it's not cost effective. And it may be that some things that are expensive seem expensive because we look at them in terms of perhaps what is their least beneficial return. But I can come back to that if we want to look at that. Next slide, please. So we began to realize when doing those sorts of analysis that working across health and education was going to be really important. And that what we found was that health interventions can leverage education and vice versa, but that the potential synergy between health and education is generally undervalued and generally poorly optimized or under-optimized. So let me just show you a bubble chart that gives you a sense of that. That's the next slide, please. So this is just looking at, and this is fairly crude, I have to say, but it's to illustrate the point. We've got three types of interventions here: health interventions in red, incentive-based interventions like school fee reductions and so forth in blue, and nutrition interventions. I beg your pardon, education interventions in green. And what we're looking at is those interventions in terms of education outcomes. And so if we look at the left, we have access to schooling, and you can see that whether you do education interventions or health interventions or incentive-based interventions, you can get returns on any of those. And if we look at learning outcomes on the right-hand side, we can see that health interventions have similar benefits to education interventions or incentive-based interventions in terms of improving learning. This isn't a competition between these sectors, but it's simply to say that all of those sectors are important in terms of the outcomes we can get. And let me make a point in the reverse direction. The next slide, please, which is showing that the decline in mortality attributed to education over 40 years here, we can see that 14% of under 5 mortality is attributable to female schooling, and that about a third of reductions in adult male and adult female mortality are also due to education. So education has major health benefits as well. Those two things go well together. So next slide. Unsurprisingly, there has been as much interest from the education sector as from the health sector in these findings. And in fact, the Global Partnership for Education has just published this version of Volume 8 called Optimizing Education Outcomes, which is specifically about school health. And I'm hoping we'll see more of that as it goes forward. Finally, I want to show in the next slide the public spending in these areas. So this is a slide which I don't want you to misinterpret, so I'll just take a moment to explain this. It's got age on the bottom, as usual, on our x-axis, and I've drawn a vertical line at 5 years of age. Investments in health under 5 years of age in low and lower middle income countries, it's about $29 billion a year, 29 billion a year. If we go above the 5 years range, we can see that the investment in education is over the 5 to 20 years, so that's a 15-year period, is about $210 billion. But the investment in health and nutrition, so this is including all the school health stuff and all the school feeding stuff, is around 1.5 to 3.5 billion. Now we estimate that needs to be somewhere around 7 billion, that there needs to be some improvement there. But the point we want to make is not that we want to see this money moved around, not at all. It's clear that we're not spending enough on any of these things in low and lower middle income countries. All these numbers need to go up. But it's particularly clear that we're missing a trick here on investing in the health and nutrition of children, because those investments leverage that 210 billion that's already being invested in education. So there's a really good rationale here for spending far more on health and nutrition than we're doing, and there's a perfectly good rationale for spending more on all of these categories. And so that brings me to just one point before I'm going to wind up, and that's about research. One of the questions people often ask is, why has it taken us so long to realize that we weren't investing in these children properly? Why is it we've been focusing on the 1,000 days rather than the 8,000 days? Well, the answer is we don't do very much research on children over 5. And when we looked at sources of publications, we found that about 95% of publications on young people were on children under 5 years of age, and that the 5 to 19-year age range is really neglected in terms of research and policy. And of those groups, interestingly, it's the 5 to 9-year-olds, the children in middle childhood, the young school children, who are the least researched and the most neglected, one could argue. So I'm going to, I think, stop at that point. I think we can. I think we've covered the area reasonably well, and I think I'd like to give you a chance to ask me some questions. Thank you very much.
Thank you, Don. Thank you for that excellent presentation, and we could keep listening. There's so much to learn. Question on how DCP3 and the global goals, the Sustainable Development Goals, how do those get informed by DCP3, and particularly this volume, which is relevant to many of our work? What recommendations are coming out from DCP3 to influence the SDG indicators, targets, work, and prioritization for countries?
Okay, so I take them one at a time, Mohini. Is that the best way to do this?
Sure, sure.
Sure. Yeah. So on the SDGs, if we look at the Commission on Adolescent Health and Wellbeing, which is published by the Lancet, supported by the Lancet, so it's very much a health thing. One of their strongest recommendations is to supporting secondary education, especially for girls. So I think that the real value of the DCP3 series in this, and I would have to say particularly this volume, is that it's starting to break down some of the barriers that we've seen between the SDGs. So it's SDG 4, the education SDG, and SDG 13, the health SDG. There's now very specific interchange between those areas. This is very much signified by GPE's decision to publish a version of Volume 8 that's specifically targeted at the education community. So I mean, let me just say, somebody in the education community is not going to pick up a book called Disease Control Priorities. So very necessary to produce a version that's targeted at the education people. It's got a forward by Julia Gillard, the chair of GPE, also a forward by Gordon Brown, who led the Education Commission, both of them former prime ministers, and both of them now saying the same sorts of things. So that's crossing the boundaries of the SDGs, which doesn't often happen.
Great. There are a couple of questions here on your slide number 14 on the classification of school-age children, and one that preschoolers who are now, we're seeing more and more of entering into mainstream education, they're not reflected, and you see that changing in the years to come. And secondly, for those kids who are out of school in the 5 to 14 year age bracket, in terms of packages and interventions that they could benefit from at the school level, what would you recommend?
So I apologize for the apparent gap around the sort of preschool area. That's partly a function of the fact that Volume 2, which focused on under 5s, and Volume 8, which focused on over 5s, that we didn't really get our act well enough together to coordinate those two pieces. The Volume 2 was published rather earlier, and I'm afraid Volume 2 really focuses, in some of us would feel, very much around the health area and not enough around the education and stimulation area. So I think that's a function of the way in which the volumes came together. So I see that as a gap. I agree with people that picked that one up. Yeah. On the school-age child, and particularly on the out-of-school child, here's a really interesting thing. If we look at the MDGs, the two MDGs for health and education, the MDG for health, some of you will recall, was very specifically about under 5 mortality. The MDG for education was very specifically about primary school education. In other words, both of those, set at the turn of the millennium, very much focused at the starting points for both the populations they were interested in, and they don't overlap at all. So the MDG for health doesn't benefit the MDG for health for education, and vice versa. Now, 15 years after all of that, both of those were enormously successful, particularly the education MDG. I mean, there are children out of school; they need to be looked after, of course. But in terms of the proportionalities, there's been a dramatic increase. And so, what are the SDGs asking for? Well, now the SDGs for education are looking at children and adolescents in particular, because they're talking about school age, about secondary schools as well as primary schools now. And if we look at the health MDGs, they also are giving far more emphasis to those same age ranges and the issues of child development. So for the first time, we've seen both of those sectors actually much better aligned around the needs of school-age children and of adolescents in schools. So this really means that we in the FRESH community need to be paying attention. Suddenly, this is all mainstream.
Great. Thank you, Don. And those were questions from my colleagues, Caroline Hilary and Jane Mutua. Thank you, Caroline and Jane, for those questions. I wonder if there are any other questions. People would want to unmute their mic. I typed a bunch of questions as you were presenting, but I don't want to hog.
Mohini, there are some questions already. There's one from David.
Yes, I see that now. Question to you, Don, from David Ross at the WHO. And he thanks you for the presentation. And for those who have not had a chance to read the details in the book, please can you tell us a bit more about what is in the 2 intervention packages you mentioned? So, Don, would you like to tell us a bit more on that?
Sure, very happy to. So the point about those interventions is that this is part of the. Sorry, I'm just thinking that probably at the end after the thank you, there probably is a couple of slides you can show that will help with that, Mohini, if you don't mind going forward through. I think, yeah. So there's 2. So we've got 2 packages. So it's worth explaining first that disease control priorities is supposed to be a kind of consensus look. It's supposed to be strongly moving away from sort of a political focus on particular things, and it's intending to provide sort of broad-based guidance, largely, I have to say, from an economics perspective. So it's looking at value for money and where the evidence is relatively strong. So this is not to suggest, I think it's very important to say, this isn't to say that these are the only possible options, but here are some that do seem to come out very strongly, that do seem to be well supported by the evidence that's available. So here we have for the school age essential package. So this is and largely thought of as a package that could be delivered through schools, and it talks about some physical health interventions and some dietary interventions. You might think of it as health and nutrition interventions. And the ones in the physical health area that are highlighted are, we can see it's deworming. We talk about insecticide-treated nets, and that's largely because the option of, that's for malaria. That's because we think the evidence is pretty strong that malaria is really important for education and for health and for development in young people, and we're seeing that more and more school-age children are being affected. But actually, we don't have a recommendation for a sort of mass drug administration for malaria. That complex reasons which we could get into. So that's why we focus on the insecticide-treated nets there. Malaria remains a huge issue for school children, and yet we don't really have the best of interventions. And then we touch on other important issues, the vaccine preventables through tetanus and HPV, oral health promotion, and then vision screening and correcting refractive error. And then on the dietary side, micronutrients, fortified foods, and school feeding. And I'll mention again that the school feeding package, very expensive relative to the others, although not expensive on a scale of health interventions, but has probably strongest benefits outside the health area. Then if we look at move out of the school age package to the adolescent package, the last slide, this one has a focus on health again, on nutrition again, but also now on mental health as an area. And the key issue around the adolescent package is that this is very much an evolving package, and the big constraint on that is how you deliver it, because in the low and lower middle income countries that this is meant to be focusing on, the school option is very much diminished. So how can you improve the access to health system programs, and how can you involve the media in that? So that's a very much a fast overview of what I think is a really complex area. I think the main message we take from this is that there are packages that are cost effective and which we're not getting out there and which children need.
Great. Thank you, Don, and thank you, David. There are a couple of questions from my colleague Caroline. One on understanding that this review or this volume has a focus on poor and middle income countries. Does it focus also on undernutrition, on issues around overweight, obesity, and to what extent? And then Caroline, your other question on under 5 mortality, if you could just unmute yourself and ask, because I don't know on what slide you asked that question.
No, thanks, Mohini. So
let me answer the first one. So one of the things I've tried to emphasize throughout is, please don't think of this as the comprehensive answer to all possible questions. This is, in fact, the first time that disease control priorities has taken on the issue of development rather than health. Most people who write for disease control priorities really like severe clinical disease or mortality as outcomes, whereas we all are dealing with areas which are much harder to measure. So it's difficult for us to grasp some of those. Also, disease control priorities, by splitting itself into 9 volumes, also, of course, wanted to avoid too much duplication. So some issues are dealt with in other volumes. And I'm afraid that the whole obesity area, very important though it is, because of course we see obesity as a huge issue in many low income and certainly many lower middle income countries. So obviously in the better off parts of those countries by and large. But nearly all of that was dealt with in volume 5, which is on cardiovascular, respiratory and related disorders, which is really focusing on the issues of chronic disease. So one of the anomalies, if you like, of disease control priorities is that some of these things are dealt with in different places, and I apologize for that. It's a consequence of the way in which they're put together.
Thanks, Professor Bundy. No, the comment was about when you said there's very little research on the 5 to 9-year-olds, and I can totally echo that from a practitioner point of view. But I think it is really because of the low mortality. So if you look at a setting where you also take into account the under 5s, then the research and the efforts are going to go automatically there where there's so much higher mortality. And I think the mortality lens has shaped the research landscape. And you're making a wonderful point that we need to look beyond mortality, but I think that's what has happened.
So, Caroline, I think that you're absolutely right, and that's the historical reason. Of course, mortality has declined very dramatically in those younger age groups. But of course, mortality has to be our touchstone in this, our major focus in this. The question we ask is, what's the point? What point do we say we've done sufficient research? I mean, I use the figure 95%. It's actually, if I take Google Scholar, I think it was actually 98% of research was for under 5s. So, at what point are we okay? I mean, couldn't we reasonably argue that maybe 10% of research should be on the 15 years after 5 years of age? That would be reasonable, that 90% should be on the under 5s, or maybe even 20% should be on children over 5 years of age. I'm simply making the point that it really is beggars beggars belief that it is so skewed, it is so remarkably skewed towards that bottom end. And yet we're increasingly aware that if we're going to invest in human capital, we have to think of children over 5. We have to think of children and we have to think of how health and education come together, because it's clear that the two of those are simply different sides of the same coin. They're all part of what we achieve, what we call human capital development. And if people are going to achieve their potential in life, we need to be investing in their health as well as in their education. And at the moment, we're not investing in their health once they get over 5. And that's really the point. But I, of course, understand why we would want to focus on mortality.
Thank you so much, Professor Bundy. And I wanted to also, since we're just 4 minutes away from the end of the hour. Yes, Song?
There's one last question that was asked earlier. I know there's only a couple minutes left.
Yes.
Maybe Don. Yeah.
I'm just trying to see which one.
Don, the question is there more evidence on catching up on brain development and height for stunted children during that 8,000 days, since most of the evidence up to now has been about the first 1,000 days?
Yeah, so that's actually an important question, which I'm just going to answer briefly. There's a whole chapter on that in the volume that's worth reading. So the story that catch up is not possible is simply not the truth in general. There may well be areas where it's not, but in general there's a remarkable amount of catch up, far more than we thought, that's available to children. And that the idea that the moment is entirely lost if intervention doesn't happen in the first 1,000 days is clearly not supported by the evidence. And you know, it would take me far too long to go into all of that. But if you read the relevant chapter in the volume, I think you'll agree with that.
Great, that's good news for us school health and nutrition practitioners. Mohini, you want to wrap up?
Yes, Song, and thank you to the person asking the question. It's been a great webinar today. Thank you, everyone, for coming in large numbers to listen to Don's presentation, a feature on Volume 8 of DCP3, commemorating World Health Day. Our next webinar will be in a month from now, on the 15th of May. That's a Tuesday, at the same time, 9 a.m. And we'll be featuring 2 speakers in commemoration of Menstrual Hygiene Day. And we have Dr. Penny Phillips Howard from the Liverpool School of Tropical Medicine, a senior lecturer, who's doing some interesting research in the Kisumu, western region of Kenya, talking about her research with menstrual cups, and we'll hear more about that. And we have Jackie Haver, a senior specialist at the School Health and Nutrition team at Save the Children, sharing with us some of the research and findings around outcomes, measuring outcomes for menstrual hygiene interventions, and how one can measure the reductions in stress, improvements in school participation, and improvements in self-efficacy. So look out for those. It's on the 15th of May. We will be sending out the recording from today's webinar, and also the information will be up on the Schools and Health site. And thank you so much, everyone, for joining. Have a good day.
Thank you, and thanks, Don, again. Bye, everyone.
Thank you all for listening. Much appreciate that. So remember, 1,000 days really important, but so is the next 7,000 days.
Thank you, Don. Thanks, everyone.
Mo, do you want to stop recording?
Yes.